now that I go in to see a patient and I tell this patient they have a disease and not something that's an outcome of them eating too much. The paradigm shifts significantly. What if somebody could come into the clinic and feel like, wow, I actually have a condition that when I eat, instead of me eating too much that causes fat, I have a body type that causes what I eat to become fat more than others. This is complex, but there are biological and genetic cues that tone this up. And there are also significant environmental influences. And we cannot deny there are psychosocial influences as well. We have eating disorders that can contribute, and we also have habits that need to be broken. All this together complicate this disease process. So when we look at obesity as a disease, I want you to think about it for a second. Does that change your paradigm? And does it change how you might look at somebody else? Now, let me just tell you a little personal story. I am a veteran of the Army and the Navy. I was an infantryman. If you know what that means I carried my stuff everywhere, and soon I found out people shoot back at you, and it's not that fun. So the Navy was a better way to go, but I was a fit and physically active person. I had a low fat mass and a high muscle mass. I was a bodybuilder, a martial artist, and I was pretty buff, as they said back in the days. I had a traumatic brain injury, and as a result, I damaged my hypothalamus and my pituitary. And suddenly my life went from a guy who was fit and I could eat as much as I wanted and never gain weight, to suddenly I could think about cake and gain a pound. Like right now, I just thought about cake and I gained a pound. This is about what my life was described as, because my metabolism decreased by almost 30%. So if you were to take and do indirect calorimetry, a testing to see what my resting metabolic rate is, you would see that if you take a known equation called the Harris-Benedict equation, calculate what I should be, I'm 30% below it unless I take medication to increase my metabolism. So my fat mass gained at one point close to 330 pounds, and I've kept over 60 of those pounds off over the last several years. Although with COVID, I did a weird experiment. I'll talk about that later. But I wanted to demonstrate how quickly people can gain weight by increasing their carbs to at least 60% of their dietary intake. The whole point of this is that's just one story for obesity. The researchers at the Mayo Clinic, Dr. Acosta, one of them who's leading the charge, has found at least 4 or 5 different phenotypes or subtypes of obesity. So in my clinic, when I'm taking care of people with obesity, we try to stratify what type they have, and then we use a patient-centered, shared decision-making approach to come up with the best individualized plan for their care. And that involves medication in some cases, and it also involves deep and intensive counseling, mostly cognitive behavioral and motivational interviewing on the behavioral sphere. It involves nutritional counseling, and it also includes physical activity. Sometimes we refer people for surgery. And just a curious note, most of the bariatric surgical procedures now have a safety rating that is lower than even a cholecystectomy, a gallbladder surgery. So we have these options, but when we can individualize the care for patients, we get better outcomes. So now I back it up to this idea of stigma and bias and the discrimination that occurs right now in the health world and in the business world. Imagine for a second now that you have a patient who has a disease that causes them to store fat more than others. Does it change how you think about that person? I have to confess, there was a time in my life where if I saw somebody with obesity and they were eating something that maybe was inappropriate from my judgmental position, in my mind, I would immediately feel like, what is this person doing? Well, they're just going to get fatter if they keep eating that. Why would they do that? But in fact, I could eat the same thing and not do it. And I justified it because I was active and fit. Sometimes when kids are in the womb, their epigenetic influence from their parents' genes and the environmental influence can actually turn on genes that preferentially turn on their ability to burn fat or lay down fat. Right now, we have an epidemic of kids who are preferentially storing fat, and we have obesity now identified before puberty, and we have kids as young as 9 years old in our county with fatty liver disease. In Garrett County, we have children below the age of puberty who have fatty liver disease. Just let that sink in, because their lifetime outcome means that they could probably have 2 or 3 decades less life. Obesity onset in adult means about 10 years less life expectancy right now, between 7 and 10 years. So factor that into our calculus for kids, and it changes precipitously. So I bring this up because the stigma and bias is real. I think I mentioned last time, and I'll mention it again today. If you go out to Google, and I want you to try this and just see where you lie on the spectrum, go to Google and look for the Harvard Implicit Bias Test. There are many tests there that you can check, but there's one in particular that looks for your stigma and bias towards obesity and weight. And actually, there are several in there that are good exercises just to see if you have any implicit or underlying bias that might be challenging your own vision of how things occur in life. So what we have to do then as a community is first recognize that it's a disease. And like most diseases, we have treatments that are available, but we also start by eliminating this bias by changing the paradigm. Instead of a fat person or an obese person, we can switch to first person language. This is a person with obesity. I am Thomas with obesity. I'm not defined by it, but it is part of who I am. But if you define me by my condition, it's a label that will have a tendency to stigmatize. So when I come into your space, if you see me and I'm maybe a little wider in my glide than others, sometimes we have presuppositions like, oh, this guy lacks discipline. Well, I'm up most days by 5 a.m. I exercise over 420 minutes a week. I maintain 2 disciplines and about a 70 to 80 hour work week for the last 3 decades. If that lacks discipline, tell me. But the judgment when I walk into a space that I'm larger than other people is, oh, this guy can't control what he puts in his face. So I went to my military doctor at Fort Detrick for some care the other day, and this is how it went down. Yes, this, and this. By the way, it looks like your weight is high, and you should really focus more on diet and exercise. Ouch. When I left that, I was deflated. So I went back in. I said to my doctor, hey, I've got a question for you. Do you have any idea what those words meant to me when you said them? And do you know that I do exercise 420 minutes a week, including cardio and strength training? Do you know that my diet is controlled? Do you know that I actually eat a whole food plant-based diet, and that I've actually managed to lose about a pound a week for the last couple of weeks? Then her eyes were wide open. She goes, I assumed, and I'm sorry. And she really did understand what that was. But this was her bias that she didn't have challenged unless somebody would have brought it up. So now I'll take it a step further. Imagine it's a clinic space or an office space, and you have a person with obesity who comes in to sit down, and they don't fit within the borders of your chairs. I came into a place just recently, and there was a chair that didn't fit the person that was waiting. So they were waddling back and forth. And I say waddling because that's the term that they described. And they said that because of their fat mass, so this, remember that because of obesity, part of the disease is biomechanical. The fat mass actually can accelerate things like osteoarthritis of the knees and the hips. And this person stated, yes, I wish I could sit, but right now if I don't move, I will be even worse off, and the chairs don't fit. And we talked about it, and they actually mentioned it to the person that they were seeing that day. So those are little environmental things that can make a big difference in the treatment of obesity. First, patient first language. When we put people first and their condition seconds, we focus on what's important, the person. And that's really where I focus all of my care. Then get to that sweet spot of what works for them, especially when we can phenotypically decide where they fit in the obesity spectrum. So I want to pause just for a moment. Did any of what I just said spark any ideas, any emotions, any thoughts, or did it create a disruption perhaps that you're trying to reconcile? I'd be anxious to hear what any of you have to say.
This is Shelley. I appreciate the invite to go take the implicit bias test, and I'm going to post that online. And I think that I appreciate what you're saying this morning. And for me, it certainly has caused me to question my attitude and some of what I have thought about people. So I really appreciate this morning.
Thank you.
Hi, Thomas.
Yes.
Go ahead.
Yes, I appreciate it as well because I'm obese. So I've had a lot of what you said happen to me. I work out 4 or 5 days a week. I've recently started, like you said, eating more plant-based, eating more fruits and vegetables. And I've even lost 75 pounds, and I'm still considered obese at 200 pounds and 5'6", but felt the best and was the strongest, but people still judged me even then, even after losing 75 pounds. So I appreciate this and getting this out to other healthcare providers as well. Thank you.
Thank you, Julie.
Thomas, this is Ronnie Glodfeldy. You talked a lot about the health consequences of obesity, and there's probably a range depending on how, what your BMI is, how much it's over what it should be. When you lose weight, you actually drop your BMI. Does that reverse some of the health consequences that can occur with obesity?
This is like playing softball when somebody knows you're not a good hitter and they put it right over the plate for you.
Right.
Rodney, you put it right over the plate for me. Thank you. The reason why we want to treat obesity so aggressively is that if we achieve even a 5% loss of total body weight, we start reversing the metabolic downstream conditions. And 10%, let me just give you a list of some of the things that occur when we achieve a 10% body loss. We can normalize blood pressure, and sometimes dropping it up to 15 millimeters of mercury. That is more potent than any drug I prescribe in practice. We can decrease A1C on an average of 2 percentage points for somebody who has type 2 diabetes. Here's something that occurs frequently in my practice. I de-prescribe medications. I have some patients right now that we're a polypharmacy with more than 5 prescribed medications, but we will de-prescribe down to 1 or 2 depending on whatever metabolic pathway. It improves kidney function anywhere from 10 to 20%. It decreases the load on your liver and can actually reverse non-alcoholic fatty steatosis. It can actually improve the outcomes of osteoarthritis, sleep apnea, prevent cardiovascular disease, and reverse cardiovascular disease when you are also having a concomitant reduction in LDL. There is a big, long list, but it's amazing that if we just shoot for 10% of the total body weight, all of those things are evident. So when we overcome the bias, and this bias occurs in media, you see it in how we present people on TV, in education. If you're a person with obesity trying to sit in the standard desk, it's very uncomfortable. I went to a school recently and I sat in the desk and went, I'm not designed for this. Do these come in men's sizes? Employment. If people are hired without being seen, they will have a higher chance of getting hired, but somebody with obesity who goes in for an interview has a less likely chance of being employed because of stigma. And in healthcare, the same thing occurs. We automatically assume things about people based on how they look. So when we go after this disease, we have to have an informed populace, we have to have an informed policymaker, and we have to have an informed provider. And what I've been just overjoyed to be able to work with Shelley and the health department, and there's a far-reaching collaboration that goes beyond just what we're doing here. But the idea is we are going to equip our providers in this community with training from the Obesity Medicine Association and the Obesity Society for treating pediatric obesity and adult obesity. This pathway will create not only a forum, but also a model of treatment in our community so we can aggressively go into our schools, into families, into social settings. Even something that's coming out of this, we have 3,000 tokens coming so we can prescribe vegetables at the farmer's market. I see Brian Bailey's on the line. He is also another co-collaborator and co-conspirator in how we can make things better. And sometimes it means taking a look from a different perspective and engaging partners that we never would have expected. One of the things I love hearing all the time is, wait, Wellspring and Mountain Laurel work together? What does that mean? But yes, we work together on many projects, and I hope to infect them with this obesity treatment project as well, because their providers, our providers, any provider in Garrett County will have an opportunity to get this training so they can actually treat obesity first. So here's the idea. If we recognize it as a disease and we treat this disease as a primary disease, then we can start making a difference. But this takes schools, it takes communities, it takes parents, it takes community action, and that's where we're organizing right now. So from my standpoint, it's something that I get excited about every day. You can tell when somebody's passionate about something when you ask them, what do you read about when you're not working? Healthcare improvement and obesity consume my diet of literature, except for I recently listened to a really good leadership series from some Green Berets. That's another time for another story. But they too are interested in taking their model and applying it to treating obesity, because in America right now, guess what the number one limitation to recruiting new people to the military? It's obesity. So if you ever thought of obesity as being a threat to national health and security, now you can link the two. So where we are at the update right now, we negotiated a position with the Obesity Medicine Association to get an extremely discounted rate for both the membership and for the two pinnacle treatment modality programs. One is the Fundamentals of Obesity Treatment for Adults. The other one is the Pillars of Treating Pediatric Obesity. They're usually pretty expensive courses, but they provide CME and they provide an opportunity even for our providers to challenge their paradigms and maybe overcome some bias even in our providers. But it also gives them the tool set to go out and help treat the people with obesity so we can make a difference. It only takes one little rock in the pond to make the ripple go out. Or some of you have heard the butterfly effect. Well, we want to be a little bolder than a pebble and a little bit broader in our wingspan than butterflies. So that's my goal while I'm here. So just for full disclosure, I am actively engineering my departure as CEO so I can focus fundamentally on obesity and weight. I'll have a separate clinic within the Wellspring sphere that's dedicated to this. We do it in-house now. Right now, we do offer indirect calorimetry, so I can measure what somebody's resting metabolic rate is. We do body composition. We do programs that are scaled specifically to the obesity subtype that people have, but we need more. We need more because if 70% of our population has obesity or overweight, we need to act now. So that was really it in a nutshell, and I can open it up for any questions. I know it's about 10 minutes ahead of what you had me scheduled, but more importantly, I wanted to see if you had any questions or if there were any things that you'd like to see more of, or if I can direct you to any other resources.
Comment. Go ahead. Somebody else. Go ahead.
Hey, Thomas, this is Brian. Just wanted to know, as we address the medical issues associated with this, I'm sure that there are behavioral health levels that we need to help with counseling and other things there. Do the programs that you mentioned or the education introduce the behavioral health component also?
Excellent question. Yes. So the 4 pillars are nutrition, physical activity, behavioral health, and medication. And we want to equip all of the providers with a bare minimum of motivational interviewing training and cognitive behavioral therapy directed specifically for weight loss. But I have to tell you, we need more. And I'll tell you why. Part of the obesity treatment algorithm is screening for depression and anxiety, which is higher in people with obesity. But this is the part that actually I'm getting teary-eyed thinking about it. In my original research, I neglected to put in a screening for adverse childhood events. So I went back to my original data pool and screened for adverse childhood events. These are significant events in youth up to the age of 21, and it can be sexual trauma, physical trauma, neglect, and a substantial amount. Over 40% of our people with obesity had adverse childhood events. And in women, it was skewed to almost double. So we need trauma-informed behavioral health specialists. Great question. Thank you, Brian.
Hey, Thomas. Can you hear me?
I can hear you.
Yeah, this is Mark. Yeah, this is Mark from the hospital. I just say a great presentation, and I'd be actually interested in giving to the medical staff as a CME. I don't know if you'd be willing to do that, but I think that would be, you could reach a whole lot of the providers quickly at one time. And if you're willing to, I'd actually be willing to be wanting to do this down at Potomac Valley for their medical staff as well. I think that I don't think that that many of the medical staff may have they may be able to benefit by picking up some of the things that you're including in your program.
Mark, I really appreciate that. And I would love to collaborate there because we actually have the funding source and the provider, the Obesity Medicine Association. But we would love to, because I know you can write for CME through the hospital, we could actually develop a local resource, and that would be really a wonderful way to go forward. The other thing we can do is integrate resources to bring some of these bariatric procedures to town, because they now have endoscopic procedures that are same-day procedures that have a great safety rating, and it would be good not only from market share, but there are some people that are reluctant to go out of the area to have these procedures. So that would be another avenue I'd like to pursue. But absolutely, I would love to explore all those opportunities. And thank you for bringing that up, because Potomac Valley, that area is really has a high prevalence of obesity as well.
So on the bariatric surgery piece, I don't think I could fit another surgeon into Garrett at this point in time until we're done our construction project. But I have a surgeon at Potomac Valley Hospital that is bariatric trained, that's going to go back through and re-credential through some not a residency, but just doing some classes and sharing some training at WVU. So we actually want to begin a program down there at this time also. So I think that the two hospitals will have a great opportunity to work with you on this, and I appreciate it very much.
Well, excellent. Thank you. This is exciting.
Thomas, this is Jenny Quarter. Thanks for your presentation. It was full of great insights and beyond time for this kind of thing to be getting some bandwidth. And I really hope that you get great bandwidth from this. Since Mark went ahead and said he wants to book you into Potomac Valley, I want to go ahead and say I'd love to get you to speak in Allegheny County at some point, or see if Allegheny County can be involved in this, sharing of information and moving the needle. I remember some years ago talking to a pediatric gastroenterologist about fatty liver disease in children, and learning that, I can't remember the year, but the year there was a tipping point expected that it would be the #1 cause of liver failure in the future. And so from a metabolic and a physical standpoint, the effects that obesity have on people eventually are just so devastating, and it's so important to work from the very beginning of life on this too. So I do also think about the teams we have at the health departments who do home visiting with young families. And I wonder, as you develop your initiative, how to outreach and educate them as well about this frame shift that people need to have when they approach people who have obesity and they're raising children, to try to bring more awareness to the family setting.
Absolutely. And I think that's where I really, I'm so grateful to be invited by Shelley to be part of a group that's looking at this. And so I get excited because this group is actually forming a plan to go and pilot in one of the schools, a small program. Like anything, you want to pilot small, work out the bugs, and then work it for scalability to see how you can expand it. I work with a family right now where the mother has obesity, the father is of normal weight. They have 6 children, 3 of them have obesity, and 3 of them are thin. And the mother is perplexed. She says, they eat the exact same foods. How can this happen? What's going on? And that's where it comes down to that genotypic influence. And sometimes when we can recognize that early, we can identify eating plans that can shift this significantly. So there's so much we can do. It's just a matter of getting the resources and knowledge to the people. So thank you.
This is Shelley. Just real quickly, I want to remind everyone that the funding to promote and to work on this is from the Maryland Department of Health Center for Chronic Disease Prevention and Control. So we've actually been awarded 2 substantial funding sources and really the focus was broadly on diabetes. But as Thomas mentioned, we're able to really target diabetes from very different avenues here. And so starting with the providers is just one way we're doing that. And the Diabetes Ad Hoc Committee does the last Wednesday of every month. So anyone is invited to that. And this would be our first book. And then they're also working with the hospital and Mountain Laurel and continuing to promote the programs that are in place in our community help to reduce lifestyle programs that do help to reduce and manage diabetes. And then, as Thomas mentioned, we are working with one school who will start already. And so they're going to be over across several months. Starting with the providers is really important, an important part of making sure we're all on the same page. And it does tie into our adolescent well child checks. So all of the things that we've been acknowledging in this meeting and the data that we know about our county, we're tying back in. So just wanted to let you all know that.
Hey, Shelley and Thomas, the hospital, on behalf of the hospital, I think we'd be very interested in participating in this. And, I think, Thomas, that the fact that you bring a personal experience to it is super powerful. So if you guys want to reach out or we want to set up a little discussion with the hospital, I'd be very interested in seeing how the hospital can participate.
Excellent.
Yep, we'll reach out to you, Mark. Thank you.
As they say, the more the merrier. And this has been a merry time, but I'm at the end of my time. So thank you so much. I really appreciate it. It's a delight to be able to share this with you. I hope I've changed a few perspectives and challenged you to rethink obesity. But more importantly, I hope that you decide to do something. This is going to be the sentinel event of our time. And if we're going to approach a pandemic, imagine if we approached obesity with the same rigor that we approach COVID. So thank you again. I really appreciate your time this morning.
Thanks, Thomas.
Okay, thank you, Dr. George. I think the value of these meetings is exchange of ideas. So very good. Next item of business is the nomination for board membership. Bob, could you tell us what the qualifications are, who would be going on, and possibly some nominations?
Absolutely, I'll do that. But I want to thank Thomas for it. It was an excellent presentation. I had my hand up the entire time, and I couldn't get a word in edgewise. So that's a good sign of a great meeting that I wasn't able to ask my questions. So I have some other questions I'll have to ask you later. So thank you so much for the presentation. I can really feel that there's some real synergy in this virtual room, and I look forward to seeing how we can move the needle on this. So with the nominations for board membership, we currently have 2 vacancies. Well, we have one person who needs to be renominated there at the end of their term, and that's Regina Gearhart. She's here today. Regina's been a great participant. She with the Area Agency on the Aging, and I think she came in midterm in her tenure for when Pam Hegeman was originally on from the Area Agency for the Aging. So as the secretary for this group, I would suggest that we nominate Regina for a second term. The second vacancy that we have that we need to deal with is actually Nicole Christian from the chamber has moved on, and that's created a vacancy there. I reached out to the chamber to Regina Schweitzer, who is the temporary CEO for the chamber, and asked if they would be interested in having somebody from the chamber be a member, and they're very interested. But at this time, she said that they would prefer not to have anybody until they get I guess the regular CEO, because Regina is just temporary. So we have one vacancy for that we do not have a name for, and so I would turn it back over to Edgar to see if there are any nominations from the floor for that vacancy.
Okay.
Volunteers.
Does anyone have any nominations for the vacancy?
Hi, this is Alicia Streets at Social Services. I just want to jump in and make sure that I am appropriately here. So our director, Rick DeWitt, has retired and I am his replacement. So I got this meeting invite and so I'm here. So I don't know if that needs formalized at all, Bob, or am I good?
Thank you, Alicia. Actually, I had notes from Beth that that she suggested that I recognize that you would be assuming the responsibilities as the director for the Garrett County Department of Social Services, and congratulations on that.
Thank you.
Also, and so you are appropriately in the meeting. Dr. Phil Lawver has retired. He had over 40 years at the Garrett County Public Schools. And so John Hummel will be assuming his responsibilities as Director of Student Services. So he'll be getting an invite to these meetings as well. And so I guess we're still back to if there's any nominations or if there's volunteers. We may have some people who would volunteer to be throw their name put their name in the hat.
Hey Bob, this is Rodney. I would do it if nobody else wants to. I mean, I had many years on the Health Planning Council, and I sort of miss it.
Okay, good. We have a candidate. Do we have any more nominations?
But anybody else wants to do it, I'll gladly give way.
Further nominations? Hearing none, I guess we'll move on with the voting. Two things we need to do, I guess, here. Bob, is this correct? We need to reaffirm Regina for her second term, and also select Rodney as a new representative. Is that correct?
That's correct. And the process, for those of you who may not be as familiar, is that we this body submits the names to the Garrett County Commissioners, and they formalize it. And so I would just say that that Rodney is eminently qualified to be on this group. So that's a great thing.
Thanks.
Okay, any other nominations? Okay, hearing none, we can have this just one vote that we select Regina, Gearhart, and Rodney. So all in favor of Regina, Gearhart, and Rodney being on the membership, say aye.
Aye. Aye.
Aye.
Any opposed?
This is Larry, and I'm going to abstain from that.
Thank you, Larry. Okay, I don't hear any opposition, so the motion is carried. So we have our new, so we have a new board membership. Next item of business is the chairperson and vice chairperson. Bob, would Steve be able to continue on?
Yes, I spoke with Steve, and he offered his regrets that he was unable to once again be at this meeting, and he's feeling a little guilty that he hadn't been able to be at many of these meetings. But he believes that his schedule should ease up a bit, and so he's willing to take the chairmanship, and he has also mentioned at that time, that he was so grateful that Edgar has stepped up many times and been able to chair this meeting in his absence.
Okay, do we have any, we have one nominated, do we have any other nominations? Hearing none, the nominations are closed, so all in favor of Steve, say aye.
Aye. Aye.
Opposed, same sign. And then, so Steve will be the new chairman. And since I'm running for vice president, I better not chair this portion. Go ahead and chair this vote, Bob.
Okay, so I'll thank you, Edgar, and again, thank you for always being available. So Edgar has been the vice chair of this group, and I guess I'll entertain motions for a nomination for the vice chair. It looked like Carl Schwalm said that he made that motion, and he's shaking his head yes. Is there a second to that motion?
Yes.
Okay, that's from Robin McGill.
Mm-hmm.
Are there any other nominations for the vice chair? Hearing none, the nominations are closed. All in favor of Edgar being the vice chair for another year, signify by saying aye.
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 Any opposed? Okay, congratulations, Edgar. You ran a strong campaign.
Yeah, good. Okay, thanks, Bob. Next item of business is agency updates. Bob, could you handle that?
Okay, yeah, I'll. It looks like there's 32 different people on the call, and so I'm going to try to reduce it so that I can see all of those people at once. I think there's a way to do that. I can only see 30. Okay, so I'll just go through, and first of all, I'll just go through the agencies, people who are representing the agencies, and then if there's anybody who's a citizen member, we'll let them do a free-for-all at the end. So let me see, Dwayne Yoder, do you have anything from Community Action?
Well, thank you, Bob. I would just mention that Community Action is in the middle of doing an update on its strategic plan, and I think we have well over 30 stakeholders that have been will be invited to complete a survey and maybe an interview. Many of you are going to be a part of that, so I would just add that the couple times that we've redone our strategic plan, it's made a big difference. It's changed the direction of our organization, and so I appreciate if you'd be willing to go ahead and complete that, because it is very helpful for our organization and our role in the community. That's all, Bob.
Okay, thank you. Donna from Alzheimer's?
Nothing today, Bob. Thanks.
Okay. Lisa McCoy from the Extension, University of Maryland Extension.
Yes, I just want to report that we are open and are returning to in-person programming this summer. So that's good news.
Thank you. We'll go to Julie from Hospice.
It's Grace.
Or I'm sorry, Grace with Hospice. Sorry.
That's okay. The funny part is that's my daughter's name.
Okay.
We had our walk for hospice this past Sunday. We had an incredible turnout, probably one of our biggest turnouts we've ever had. So we just wanted to thank everybody in the community for the support for that. And that's really all for us.
Okay. Now we'll go to Julie for AHEC.
Hello. There's really not much going on. We're still working from home, but we are trying to get out into the community more now that if things are starting to open back up. And if you guys are having any health fairs or anything, just let us know. We would like to attend anything that we can. Thank you.
Thank you, Julie. And just so everyone knows that we are on the schedule for the health fair is for next April. We already have a date locked in and reserved at the CARC. So we're hoping to get back for that. So thank you for bringing that up. Mark from the hospital. Or maybe Kimmy Scott, if Mark had to leave.
No, I just had to unmute myself. Sorry, Bob. So I don't really have anything to present at this time. Other than the hospital is about to sign a letter of intent with WVU Medicine to become a full member. And I think the value of that for the community in general is that we'll have additional resources and more programs that we'll be able to bring to the community in terms of specialty care and specialty visitation of physicians. Sometime, later on in the summer, I think as the pandemic winds down a little bit more, we'll be holding some community forums, and we would love to have members of the Health Planning Council present to ask questions and to, address any concerns that people may have about advancing our partnership with WVU Medicine. And we'll be able to present the additional services that we feel that will become immediately or quickly more available to the community, and just talk about it, I think, and get the community's perspective. So I think we'll be looking to do that sometime in late July, early August, possibly September. The letter of intent for the hospital really begins probably about a year-long due diligence process in which we'll have to continue to investigate the real feasibility of it. But the letter of intent provides a confidentiality between both organizations to disclose confidential information and how the operations of each organization run. In addition to that, pain management is just going like gangbusters. It's doing really well. Urology is doing really well, and I think that the community has embraced a lot of this specialty and subspecialty services that we have brought to the community, and we're grateful for that. And of course, we're also open to more community planning, and we've integrated elements from the community health needs assessment completed by the health department into our strategic planning process, so that that we're addressing community concerns and sort of use that as a listening post for the community. But really, other than that, things are going well. The hospital had a good year this year. We expected to lose money and ended up making a small profit. And really, we expected to lose money mostly due to the number of services that we simultaneously brought live, including the recruitment of general surgeon, a new orthopedic surgeon, urology, pain management, behavioral health services. So if you can imagine, that's quite an undertaking to try to implement all those services at one time. But even though we predicted a loss, we believe that we will be here with a financial positive, and we're just continuing to do what we do, and our quality continues to be impressive, and more celebration, I think, coming around our top 20 celebration, at least within the organization in the hospital. So thank you for the opportunity.
Hello, this is Robin. I would like to add that the hospital gala will be this year on November 13th, which is a Saturday, and it will be up at WISP. And we hope that all of you will plan to come to the gala. It'll be a lot of fun. It's a masquerade. And please look forward to that at the WISP on November 13th. Thanks.
Robin, thank you. I forgot about the gala. Yes. How could I forget?
Good.
Thank you all.
Thanks, Mark and Robin. Brian from Mount Laurel.
Hey, thanks, Bob. Yeah, just one thing. In the second and third week of July, Mount Laurel is doing its annual sports physicals at our 3 locations. So just want the Health Planning Council, anybody who has any children in school, we do the free annual physicals, so they will be held at our different locations. They're on our website, and the requirements for bring some forms to fill out. So look forward to helping kids get back out there and do some sports in the community.
Thanks, Brian. Fred from the Behavioral Health Authority Local Management Board. I must have caught Fred off guard.
Hey, no, I had to get my phone out of my pocket.
Okay.
I'm headed in. Hey, I don't have any major stuff. I just wanted to let people know that our office had submitted a screening, brief intervention, referral to treatment grant through SAMHSA, and we believe we made it through the final screening process because we did not get a "you don't qualify anymore" email from SAMHSA. So we're hoping that that's good news for the county, and it'll help in relation to what Thomas shared earlier. It will provide an opportunity for primary care offices to implement some screening tools to assess for a lot of different conditions, primarily anxiety and depression. And we would then invite the Duck Center and other providers who have an extensive interest with adverse childhood experiences to become members and part of the grant. Our office worked with Shelley and John to get the grant submitted, and I think Shelley's identified as the planner, and I'm the project manager. So hopefully we'll have some good news maybe next month with regard to that. And then Bob, I didn't know if you wanted to mention about the other program that the local management board is working with regarding the survey that's going to be implemented in the county.
Sure. What Fred's referring to is the CDC VACS program, VACS, which is Violence Against Children screening, and that is the CDC. There's is piloting in Baltimore City and in Garrett County the process with which they hope to undertake to do a violence against children screening survey that could possibly be nationwide. The World Health Organization and the CDC actually funds this screening in numerous other nations, but they've never done it in the United States. And so the local management board will be working with them in order to develop a process, and it's not actually to do the survey. So but it's the process, and they will be working with people in the community to do that. So, and that's Centers for Disease Control is the funder, and NORC, which is from the University of Chicago. It's a think tank and does a lot of research. They are the primary organization that's leading that up. So it's great to be part of such a great research program. Thomas, do you have anything else from Wellspring?
You guys heard enough from me. I'll save it for next time.
Okay. Alicia from Social Services, do you have anything you'd like to report?
Yes, just a couple of things. We are still seeing appointments. We've been seeing in-person appointments since June 1st. We are still encouraging our customers to call and do appointments with us to schedule them. We are not open to walk-ins today, but July 1st, we will be opening our doors again to walk-ins. We are still encouraging phone appointments, and we are also testing a virtual appointment model through Google Meets. We're getting a little bit of pushback with that from our headquarters office due to some security concerns. However, we have learned that, particularly with a lot of our customers and their transportation issues, we've gotten quite a bit of feedback, positive feedback, for having the ability to do phone interviews with their case managers and also any virtual appointments. And these mostly I'm talking about are in our Family Investment Administration unit. Of course, our services unit, which is handling our foster care, CPS, etc. Those have been in person for visitations and things all along. So when I'm talking about in-person appointments and virtual, mostly talking about our Family Investment Program. We are also converting over to a new phone system, which is VoIP, the second week of August. So if any of you have had difficulty contacting us over this past year, please know that we should have better service in that area very soon. But we do have people staffing our phones now. I had some feedback a while back that people were having difficulty reaching us or getting return calls. So that should be alleviated or at least improving. If you're not having that experience, please reach out to me because I do want to know if there are problems with that system. And then the only other thing in relationship to this group that I appreciated hearing early on, we are looking at a trauma-informed care program here for our social workers, which is going to be combined with sort of a wellness program. So we are just in the preliminary stages of talking about that, but given the work that our social workers here do, I'm very interested in looking at trauma-informed care, secondary trauma types of trainings and programs. So looking forward to hearing thoughts about that from this group. And if any of you have those types of programs, I'd love to hear more about them. So that's all. Thank you.
Thank you, Alicia. Scott from Appalachian Crossroads.
Hi, this is Scott. Just one little bit of good news. You all see all the help wanted signs all throughout the county. And the one positive part of that is we've been helping a lot of folks with disabilities get jobs. So
That's great.
It's good for them and good for lots of different things. That's all I have, Bob.
Great. Commissioner Larry Tichenal. Larry, do you have anything you'd like to report from the county?
Actually, everything's pretty good with the county right now financially, and I really don't have anything else that I need to report on. Thank you, Bob.
Okay. And I think I've gone through the agencies except for the health department, and I'm just going to jump in and I'm going to put Shelley will be able to talk about the CHIP in a moment, but I just wanted to give just a couple things from the health department. And one is, for the past 14 months, we've always reported on COVID. So our numbers right now are 0.8%. So that's less than 8% or less than 1% of the tests that people are getting for COVID are coming back positive, and our current case rate is 49. And just put that in perspective, we've only had one positive case in the last 10 days. So the vaccines are extremely effective, and we're really continuing to want to encourage everybody to get those vaccines. A couple of other things just to let people know what's going on here at the health department. One is that we've received a comprehensive addiction and recovery act grant. It's a 5-year grant, and it's to address reduce opioid, methamphetamine, and prescription drug use, and especially targeting youth. We've also gotten a one-time substance abuse block grant supplemental for funding for prevention services, and that's really, it's substance abuse prevention, but it's really tied to the COVID funding. Another thing that's happening here is that fits in with Thomas's presentation is we have a take off pounds sensibly group that meets here at the health department on Wednesday evenings from 4:30 to 5:30 in this very conference room, and the cost for that is $32 per year, but we have 3 slots that are available that are scholarshiped. And so if anybody knows anybody who would like to and interested in participating in that, they can call here to the health department, 334-7730, puts you in community health, and that's where they would be able to register that person. And then the other thing, just to let folks know, as far as Medicaid coverage, our medical assistance unit has been working on that, as well as social services. But during the pandemic, anybody who has coverage, that's not going to lapse until at least December 31st, 2021. So people who have become eligible because of unemployment or so forth through the pandemic will remain eligible until December 31st. And then Shelley, would you like to speak to the CHIP?
Yes, thank you. We did, amidst all of the additional grant writing and all of this COVID stuff, we were able to publish the Community Health Improvement Plan. You all can find that, of course, on mygarrettcounty.com. It's under My Community, and it's actually at the very top. Some version 2, issue 1. And I just want to give a shout out to John Corbin, who develops and codes all of this stuff. We've been working on this for 5 years, as many of you know, and you've been right there with us. It is a part of our process, is a nature model practice, and it has become rather seamless. So the initiatives and a lot of the strategies that people are actively tracking and actively working on, our data is uploaded every month, and we're able to pull those strategies in and publish an up-to-date CHIP for you all. This one is bundled with our assessment and some of the other data that supports the strategies. So you have the option of downloading the small strategy version or the entire document. I do want to remind you that it is rather lengthy, and print is the old school, right? So we all are working on our computers, and because of the nature of the way that we update everything, anytime anyone uses My Garrett County and updates a group, it's responsive and it changes our CHIP. So it's just pretty incredible to be on this side of it after 5 years and see the community, all the different agencies and everyone working together to produce such an amazing thing. So thank you all, and it's there for you. We'll start our media push and that type of thing next week, but it's there for your review. Please reach out to me if you see any kind of typo. It's not too late for me to change it, or any questions that you may have about it. So thank you.
Thanks, Shelley. And CHIP, just to remind everybody, means Community Health Improvement Plan. So we work in it all the time, and we know exactly what that means. But if you're not familiar, CHIP is Community Health Improvement Plan. And then I guess it's the free-for-all of anybody else who is participating either, with an agency or who are community members who are on the line, is there anything anybody would like to report?
Hey, Bob, this is Rodney. You might want to talk a little bit about the progress we're making in vaccinating the high school students. You're working with the Board of Ed, right?
Yes. So we've had two, well, I guess it's been 4 clinics now with that have been at the 2 have been at Northern and 2 have been at Southern High School, and using the Pfizer vaccine because of it being approved down to age 12. And we have been able to have a great collaboration on doing that. Of course, the thing that we're all concerned about is any type of variants, and as well as if there's a kind of a resurgence in COVID in the fall. And so we're really encouraging people to get vaccinated. We're trying everything we can, but the progress at this point is very slow. It's slow nationwide. I would say that Maryland has done extremely well and is in, the top 10% of states being vaccinated. But because of our proximity to West Virginia, I would say that West Virginia is in the bottom 10%. And so we're kind of right in the crosshairs there between the two. And so we really, we are still able to vaccinate here, as well as all the pharmacies. We're trying to work with primary cares to be able to vaccinate. And so anybody who needs a vaccination can call here to the health department, or then go to the pharmacies or primary cares. So thanks, Rodney, for bringing that up.
Well, I was just interested in how receptive the adolescents are being, and their parents, and bringing them into the.
I don't have that number in front of me, Rodney, but it's not extremely receptive as the ages go down. It does. Obviously, our highest percentage of people vaccinated are over 65, and we're well over. I think we're at 74% of people who are over 65 are vaccinated, and that goes down. I recall that the clinics that we had right around 30 or 40 youth who were vaccinated there, as well as we've had some that were vaccinated at Walgreens, because Walgreens had the Pfizer vaccine before we did, and they were able to vaccinate some youth there. So that number, we'd obviously like to see that go up, and we may be doing some more things as the beginning of school year begins, to try to get that message out to get vaccinated.
There is a major concern in the medical community about myocarditis in young people. And I'm wondering, have you seen that at all in Garrett County? Because people are very concerned about that in adolescents.
We haven't seen any reported cases or heard about any. I have not heard about any reported cases of myocarditis occurring in a temporal association with vaccination in our county. I know that they are reviewing the data that exists at the national level about myocarditis. And up until now, we just have to assume that the incidence of myocarditis during, say, the month after a vaccine has not appeared to be any greater than the incidence of myocarditis in any other year prior to COVID. Because, as you know, myocarditis is seen every year, and it's not a common diagnosis, but the question is it being recognized at any higher, incidence than the background that we already know exists. So we're waiting to hear about what they say about that. But no, I do not know of any reported case of myocarditis in Garrett or Allegheny following a vaccine.
Thank you. My other question is, are you counting the adolescents who possibly had the coronavirus, the COVID? Because they, from what I've been reading and hearing, they are not encouraging those adolescents or teenagers to have the vaccine if they've already had immunity, that it doesn't really help. I don't know if that's the case up here or not.
I know of no carve out for a special recommendation for adolescents versus anyone else. And the only carve out that was that sort of indication that there's no real need to hurry and get it in the first 90 days after an actual disease, but that it's still recommended as you get farther away from your natural disease. I have not heard that there's any different kind of message to be given to adolescents.
Okay, thanks.
Robin, thanks for those questions, and also just to let everybody be well informed that the numbers that we have, and when we put up percentages, those only include people who are vaccinated in Maryland. So if somebody is vaccinated in Allegheny or Washington County or whatever, they will be reported. Those folks who are vaccinated in West Virginia, WVU, or Potomac Valley, or some their provider happens to be in Pennsylvania or in West Virginia, they do not show up. So our percentages are maybe slightly higher than what you're seeing. And also we know that there is a great deal of hesitancy among people who have already had the virus, and our recommendation is they still get the vaccine. But we also know that there are quite a few folks that are hesitant for that because of the belief that they still have some protection. So, are there any other questions or any other comments from the group? Okay.
Marion has raised her hand the way it looks.
Oh. Thank you, Marion. You can go ahead.
Go ahead.
We can't hear you.
You have to turn on your mic.
Okay. Yeah, you might want to unmute.
So, Bob, you reported a 74% vaccination rate for the 65 and over, which might be artificially low. Do you have similar data on the younger groups, particularly the adolescents? That 30 to 40 kids being vaccinated in the 4 clinics seems kind of low.
Yeah, I agree.
Yeah, we get reports on that, and we don't we could add those to our metrics, but the metrics that we tried to keep them pretty clear and not put too many metrics up there, but we are able to get a report, and we can say how many people are in that age group. And what we can do is I can actually maybe send out to this group the most current for that age group that will tell you exactly how many people have been vaccinated, and it may even be able to tell you the percentage in that 12 to 18 cohort. So we can do that, but we just don't report that on our website because we try to look at the over 65 and the 12 and the 12 and over the percentage that have been vaccinated.
Bob, yesterday I was listening to a meeting at the state level, and I didn't write it down, but in my brain's functioning correctly, I think overall 12 to 18-year-old cohort in the state, 30% have had at least one vaccine. I think that's right. But again, we should check that. And then if we're like the rest of the state, we'll be below that 30% with at least one. I think 20% was fully vaccinated and 30% had at least one or something like that. So just to give you a reference point.
Dr. Corder, this is Rodney. When you're talking about the immunity that occurs because you get the disease and the immunity that you have because of the vaccination, you think they're comparable and how long that immunity will last? And second question is if and when there's a recommendation for a booster vaccination, how will that impact the people that have had the natural disease, the current disease, instead of the immunity from the vaccine?
Okay. These are great questions. In general, over the history of, being able to vaccinate for any disease, in general, natural disease confers superior immunity to vaccine-induced disease. For example, if you get natural measles and you survive it, you're going to be immune for life. Versus if you get vaccinated for measles and you don't get natural disease, you're going to need a booster to maintain. So that's an example for you. That should not minimize the fact that vaccines have saved countless lives and are one of the greatest achievements of public health. In terms of, how long do we know how long either of these immunities are going to last to COVID-19? No, we don't know how long that the vaccine-induced immunity will last, but we're watching and studying it along the way, and we don't know how long natural immunity will last, but it's being studied in real time as well. I think this week there are meetings going on at the federal level regarding need for booster doses and timing and things of that nature. I don't know what would come out of that, but it's certainly, being studied. The thing about coronavirus, similar to influenza, is that it changes rapidly. So the immunity we have, whether it's from natural disease or whether it's from vaccine-induced immunity, is to whatever flavor we were exposed to. And if that changes greatly, it may not completely protect against something that's a variant. However, in general, history would say that you'd have some degree of immunity, some cross-reactivity that would be protective, and that perhaps we wouldn't get as sick as we would have. And I hope that helps, but it's such a changing in real time and learning in real time, so I don't really have all the answers.
Yeah, there's a lot of questions on it right now. I think they have to answer. Thank you.
At least there's blood work that you can have done to see what your the amount of antibodies you have if you've had the COVID and not had the injections. So that's encouraging, a way that they can follow that data.
You can check antibody levels after natural disease. You can check antibody levels after vaccine-induced immunity. The general, if you go to LabCorp and get that done today, that's just going to be absence or presence of them. It doesn't measure how functional they are. Those are much more sophisticated testing. That's not the usual LabCorp test. But you're right, you can test for the absence or presence of them. And in general, we assume that they will have some degree of effectiveness if exposed again.
Thanks.
Sure.
This is Tiffany from the Personal Health Department, and I'm looking at a report that was published June 11th of this year. And for the first dose, with individuals in the county at least receiving one dose between the ages of 12 to 15, the county percentage is, it looks like 11%. The state average is 34%. Again, ages 12 to 15 receiving the full vaccination doses, it looks like for the county average, it's 4.54%, and for the state average, it's 15%. And again, it looks like this report was published June 11th of this year.
Thanks, Tiffany.
Sure.
That's not good.
No, it's not good. And we are certainly positioned in the wrong position should, say, the Indian variant arrive. They call it Delta now, sorry. If the Delta variant were to come here, which is the variant that's causing most of the increase in cases now, it's growing rapidly in the country. And yeah, that would be unfortunate. I do want to just plug testing, continuing testing, because, and I mean surveillance when I say this, it's obvious at this point we need to test anybody who has symptoms suggestive or anybody who's been exposed to a known case. But beyond that, I would like to encourage just regular surveillance testing, especially among unvaccinated people, as much as we can, because that's how we're going to be able to trigger contact tracing, isolation, quarantine, all the stuff that we need to do if and when we have new cases.
Looks like Marion has her hand. Yeah.
I have raised my hand again. Certainly this challenge of getting the vaccine to younger cohorts is one that everyone is facing, not just here in Garrett County. But having heard a few things today on the phone, like the questions that have been raised about the risk to kids, the fact that you have upcoming sports clinics, I wonder if there could be some modest effort to address any questions that you think are out there from the parents of the younger kids, and then maybe to try to make the vaccines available if it's not already planned when you have the sports clinic. But first, to get at the issues that are blocking the kids and the parents from wanting this vaccine, because this Delta variant is growing exponentially around the country. I heard data yesterday from a colleague from NIH that was frightening, in fact, in terms of how fast it's going to hit. And it's going to hit in the fall among the unvaccinated here in the county if something isn't done to increase the numbers. I know you guys are working at a rapid clip on so many levels and in so many ways, but this is one that if it's as simple as addressing some of the questions for the parents, maybe that could be put out there in advance to get them to begin to consider what could happen to the kids. And in terms of boosters, the latest data that I have heard as they're discussing this in DC today is that those of us who are vaccinated may have an 18-month immunization period, where once they were thinking we might have boosters as early as 12 months.
Well, the vaccination of the public, and particularly the adolescents, is going to be a major factor in allowing us to keep the public schools open again next fall. So I really want to encourage people to get out there and get the vaccinations. It's really important for this community to be vaccinated.
So I agree with that, Rodney, and perhaps we'll do a blitz along with the with Garrett County Public Schools on trying to get that information out. Again, our clinics were we threw them together pretty quickly in order to get those out before the end of the school year, at least the first dose, and then the second doses. And we had a few first doses that came out. That was after the school year had actually ended. And so we do need to focus on that some more. But our numbers, we see that Garrett County's numbers seem to match what's in West Virginia a little closer than what they do for what's in the center part of the state. With that, I'm going to turn things back over to Edgar if you want to close the meeting. Or
Okay.
Mr. Chairman.
Okay. Good participation today. Really pleased with it. Is there any other business to be brought before the council before we adjourn? Hearing none, I pronounce the meeting adjourned till next month. Thank you, everyone.
Good, everyone. Have a great day.
Hey, what's the Wi-Fi for this?